Hello and welcome to Checking the Vitals, a podcast powered by SpecialtyCare. I'm Todd Schlosser, and joining us today is Kurt Strudwick, a clinical educator for ECMO services at SpecialtyCare. In today's episode, we talk to Kurt about how a family tragedy in his youth led him to have a passion for working in healthcare, how he started working in extracorporeal membrane oxygenation, which is what ECMO stands for, and how he has taken his vast experience at ECMO to help hospitals across America start their own ECMO programs. Enjoy the conversation. So joining me today is Kurt Strudwick, who is the National Clinical Educator for ECMO services at SpecialtyCare. And this is the first time we've had what I will say an ECMO specialist on, someone who focuses on ECMO. So I'm going to be picking your brain a lot about that specifically later in the episode. But what I'd like to do right now is talk to you about why you wanted to work in healthcare in general. So what was it that brought you to that field?
So I think I was born into a family of health professionals,
Okay.
But my main inspiration came from my mother. She was a pediatrician.
Oh, okay.
I think the triggering point for me was when she got diagnosed with cancer.
Oh.
And she 6 months later lost her battle to cancer.
Sorry to hear
and
that.
I typically tell people that like a personal experience like this can do one of two things. It can either consume you and make nothing out of it, or you can go on and continue to live their legacy and inspire people and make a difference in their lives. And I obviously chose the latter.
Yeah, absolutely.
So she passed when I was going into high school. So I kind of knew I wanted to go into the medical profession, but I didn't know exactly what.
Sure.
So my path focused heavily on the sciences, of course. And college provided me that exposure to different avenues in medicine. Being affected by asthma as a child, that was kind of what drew me to focus on the lungs.
Like respiratory issues, right? Yeah, absolutely.
And I remember sophomore year of college, I was, like going through a midlife college crisis like a lot of people do.
Yeah.
And it kind of like dawned on me. I was like, oh, it says respiratory therapy. And I was like, this must be a sign. So from there, just kind of like found out more about the profession. And I was given the opportunity to work in pediatrics and neonatology at Johns Hopkins in Baltimore.
Yeah.
And I invested most of my time in the pediatric cardiac intensive care unit, which is where we predominantly did our ECMO.
Yeah.
And it was just like so fascinating. And that's where I became trained as an ECMO specialist, and it just took off from there.
And you just sort of made a career out of that specifically, it sounds like.
Yeah. Yep. I fell in love with ECMO and kind of just like jumped ship off the respiratory train.
Well, I would still say that they're somewhat related, although normally when ECMO comes up on Checking the Vitals, it's because we're talking to a perfusionist who also assists in ECMO. So can we talk briefly about how it's different? So can you give me a basic explanation of what ECMO specifically does?
Oh, yeah. So ECMO is a form of extracorporeal life support. Mm-hmm. And it's able to kind of augment oxygenation and ventilation, as well as cardiac output by a cannula that is inserted into the patient's neck or femoral vein or artery. Mm-hmm. And it removes the blood from the patient's body, pumps it through a circuit, and when it passes through the circuit, it passes through an oxygenator.
Yeah.
And this oxygenator plays the role of the heart and lungs.
Yeah.
And it oxygenates the blood and removes CO2, and then returns the oxygenated blood to the patient's body. This allows the patient's sick heart or lungs, or both, to rest while the medical team tries to figure out what the underlying problem is and, treat the underlying issue.
I would assume that it's used a lot to give the body a chance to rest and recover, because it might take a while for whatever is going on. It could be a virus or it could be anything. I'm sure you know a lot more about it than I do, but it could take a while for that to dissipate to a point where the heart and lungs can take back over, I'm assuming. Is that at all correct?
Is 100% correct.
Okay.
Sometimes you see, it depends on the underlying cause, obviously.
Sure.
So
Yeah.
if you see a patient that, like a baby that is on like a meconium aspiration, who probably only needs ECMO for 3-4 days, maybe.
Right.
Or you could see somebody with COVID and they end up being on ECMO for 4 weeks.
Yeah.
So it kind of varies.
And that's actually an interesting distinction between like perfusion, like running a heart and lung machine during surgery, which can last hours, but which is a long time. But ECMO, it's usually days, sometimes weeks, as you just mentioned, for a lot of COVID patients.
Right.
So does a technician or a specialist, as you were, do they need to be in the room where the patient is receiving ECMO 24 hours a day with that ECMO patient?
Yes. So the ECMO specialists, they are at the bedside 24/7.
Yeah.
And in my experience as a specialist, because you can't leave the bedside at all. If you needed to take a break, you'd be braked up by another ECMO specialist or perfusionist or somebody else is trained in ECMO.
You'd be sort of relieved, and then you come back and take back over. Sure. Yeah.
Absolutely. And obviously that's because in the blink of an eye, anything can go wrong.
Yeah.
So you obviously have to respond quickly and appropriately in the event that something like that should occur.
I mean, the ECMO machine is essentially acting as the heart and lungs, which are two of the most important organs in the body.
That is exactly what is keeping the patient alive.
Yeah.
If something happens to that machine, chances are, if it's not corrected almost immediately, that the patient could die.
Yeah. And the patient outcomes are the most important thing in this line of business. So that's paramount no matter what's going on. So while you're there, and I just wonder, while you were at Johns Hopkins doing this and sitting by the bedside, you were in pediatrics too, right? So it's just like children you're sitting there with. Are you able to talk to them, or are they intubated and sort of, for lack of a better term, asleep during this?
In pediatrics, they're intubated and completely sedated, because there's no way that you can rationalize with a 3-year-old that you have these cannulas coming out your neck and you need to stay still.
That was my question. I have a niece and nephew, and there's no way they would allow that to happen at that age. Yeah.
So typically, like our pediatric population or babies, they're typically intubated and on drips to keep them comfortable and keep them sedated.
Yeah.
Whatever the later advancements in ECMO is, so if it's being used as a bridge for like a lung transplant, those patients, once they go on ECMO, they can, be extubated, they can get up, they can walk, they can work with PT. So that's one of the things that you see with a lot of the bigger centers they're doing, is getting this like early mobility. So there's no point to keep an adult or, like even a teenager who you can, rationalize with. There's no reason to keep them heavily sedated and intubated. So you can get them up and walking and moving until the time comes for them to have a lung transplant.
Oh, so they can get up and walk around when they're on ECMO?
Oh yeah. Obviously not the more severe where it's total heart and lung support.
Sure.
But if they're on the ECMO support purely for their lungs and their heart's fine, they can get up, they can work with PT, they can walk around, and it takes a lot, but.
Well, I'd imagine you're sort of wheeling a machine around with them. You're sort of following them with the machine.
You have the tubing coming out. It's a production, but.
So you worked at Johns Hopkins for, it seems like it was 6-7 years. Is that about right?
Yeah, almost 7 years.
And you did that as an ECMO coordinator, or in the ECMO capacity for that long?
So our therapists play both roles.
Oh, okay.
Yeah. So you kind of function as both a respiratory therapist and an ECMO specialist.
So can I ask, and I realize this is deviating from the ECMO area, but what exactly does a respiratory therapist do day to day with patients?
It could be as simple as giving a breathing treatment for an asthma attack, or it could be doing chest compressions and intubating a patient and putting them on a mechanical ventilator.
Okay, so that's a pretty wide disparity from one to the other. Yeah.
So it kind of varies. Obviously, if you work in an intensive care unit, especially now during COVID, I can only imagine.
Yeah.
It's crazy because COVID's attacking the respiratory system mainly. Yes. So I'm sure all the respiratory therapists are just slammed right now.
Oh, I'm sure that's true. And then it sounds like, at least at places like Johns Hopkins, where they sort of pull double duty as far as respiratory therapy and ECMO duty, they're even more so
More
busy.
slam,
Yeah, just because they are that. And maybe we can focus on that a little bit. But it seems to me, and obviously correct me if I'm wrong because you're the expert, but it seems to me like ECMO or going on ECMO is sort of the last line of defense against COVID for a lot of patients. And I don't know exactly why that is, but I think it is because it attacks the lungs and you're just trying to buy them more time.
Yeah. So the outcomes vary, obviously.
Yeah.
And it depends on like institutional practices. But typically what I tell people is that you shouldn't wait till the last possible moment to put a patient on ECMO. You should have thresholds. And once the patient meets that threshold, then you just put them on. That way, because what you're finding, especially with the patients whose lungs are severely compromised, is that you're taking a lot of pressure from the mechanical ventilator to, like essentially keep their body's pH normal.
Yeah.
So obviously, as you increase that pressure, you increase the settings. This just poses more and more problems in regards to like, lung protective mechanisms and strategy. So that's something that could be considered is if you put them on ECMO sooner, are the outcomes better? But
is there any data to suggest that?
It's way too soon to,
Yeah.
especially if this just happened in the past 9 months.
Yeah.
So I think people are still just kind of like making educational, team like a team effort.
Yeah.
Making the best educated guess that's possible.
And that's really all you can do at this point. It's interesting, and it's been interesting to see this from I call myself a bystander just because I sort of work in the healthcare field, but I don't actually practice any medicine, right? I just sort of help people tell the stories. Yeah. But I wouldn't say, like, if you asked me what you should do, I would be like, you should call Kurt because I have no idea. But I think that a lot of people look at the medical community as, well, they're the experts. They know what they're doing 100% of the time. But when things like this happen that are sort of maybe not brand new, because we've dealt with coronaviruses before, but not specifically this one, and it's always a little bit different. So it's really just seems to be that the medical community is taking educated guesses and then capturing the data so that later, once we have enough of a sample size or data set, if you will, we can make better educated guesses.
Right.
And
obviously, like in the future, it won't be educated guesses anymore because actually have that research information. So even to this day, looking at the data that started in March when like the COVID pandemic started taking off.
Yeah.
In comparison to the data now, it's exponentially improved.
Yes.
So and obviously that's like sitting down, reviewing the information that's provided, and kind of like making better practices or better clinical decisions, I should say. I shouldn't say guesses. Better clinical decisions going forward.
So is that something that as a national clinical educator, you have a hand in as far as what is the best standard of practice for like specialty care where you work?
Yeah. So for me, as the clinical educator, I work with our clients all over.
Okay.
So the entire United States, wherever we have an account, it's kind of my responsibility to, like if it's a new account, getting them up and going and like getting them on their feet. Or if it's an account that we've had for a while, I have to stay up to date with the information and the data and that kind of stuff.
Sure.
To be able to send that information and be a resource to these people because I'm supposed to be the clinical expert for the division.
Yeah. So do you mind if I ask how you stay up to date with what is the latest and greatest in ECMO? Or is that a trade secret?
It's not a secret.
Okay.
I get a lot of my information from ELSO, which is the governing body for ECMO.
Okay.
It's the extracorporeal life support organization.
Sure.
And for every ECMO case that it's done, you pretty much like input all this information into the system, and they kind of maintain that data. And I'm able to like access the data and look at it and see what the best practices that other big institutions are doing. and how they're improving their outcomes.
And I'd imagine that once you get that data, you are then sort of in charge of disseminating it across all of Specialty Care's accounts, wherever that hospital is. You're sort of on the phone, I'd imagine, calling them, or maybe even doing Zoom sort of.
It can be
trainings.
On the phone, it can be Zoom, it can be in-person training, but which is a little bit difficult now, of course, with the pandemic.
Yeah.
But yeah, and the position itself is relatively newer.
Yeah.
So it's kind of like getting that information out to the accounts and letting them know that there is an educational resource that they can reach out to. So of course, the more that happens, my emails just keep coming in.
So how long has ECMO as a service line or specialty been around?
So ECMO started in the 1970s.
Okay.
1970s.
So shortly sort of after the heart and lung machine and perfusion has started, because that was maybe 50s, 60s, and then ECMO came online.
Which is kind of just like, and cardiac bypass outside of the operating room.
Yes. Yeah.
And for a longer period of time, obviously.
Yeah, because it's not hours, it's days and weeks.
Right.
So have you seen a much wider adoption of ECMO as a service post-COVID? Or was it pretty well regarded in the industry as a option for a lot of patients? It just wasn't done as much.
In the 1980s,
sure,
it was kind of like a treatment for neonates. It didn't really have much of a take in the adult world.
Sure.
Probably until the H1N1 pandemic of 2008, 2009.
Yeah, okay.
That's when you started to see more of these adult intensivists gravitate towards ECMO, because in previous years, it was more so for the pediatric and neonatal population.
And then I'd imagine once COVID came around, it started to open up and a lot more people are using it. So do you think post-COVID that ECMO has sort of established itself as a standard of practice, or at least a good option for a lot more medical issues than before COVID?
Yeah, I think so, especially because COVID what happens to the body is that it kind of falls under this umbrella title of like acute respiratory distress.
Yeah, or ARDS.
Yes.
Yeah.
Exactly. So with that happening, like other things can fall under that umbrella as well. So if a patient is diagnosed with severe ARDS, and they meet that criteria that we talked about previously, that the institution comes up with, because like the threshold, it's kind of like recommendations.
Sure.
So the governing body, they can recommend that, like you have a PF ratio less than this, that you should go ahead and put the patient on ECMO.
Right.
But it's still up to the physician and the institution how they want to run their program.
Sure.
Some people are a little bit more, conservative. Some people are more liberal, and they're like, okay, let's try and put this patient on.
Yeah.
So I think when people have started to see the value that it truly brings to the table, especially despite the fact that it's more recent, they're definitely seeing it as a positive option. And that's kind of why when we talked earlier, I kind of focused on not waiting until it's the last possible thing that you can do, because probably it's too far gone then with the patient etiology, whatever their disease is. But if you kind of like pull that trigger sooner or sooner, the outcomes could potentially be better.
Right. And that's sort of the data we're collecting now, I'd imagine, throughout, all of these extra cases we're seeing because of COVID, is going to be sort of a data boon for ECMO. And then we can look at that data and say, yes, there might be a too soon for ECMO, but there probably is I'm sure there's also a too late for ECMO.
Yeah.
And we got to find that sweet spot.
Perfect.
Yeah. So is that something that you have a hand in as the national educator for ECMO, or is that more of a data scientist and you sort of disseminate the information?
I think it comes down to physician practices. So they can reach out to me as the resource or as the expert, and I can give them my input or my take on what they should do and how they should modify it. And it's up to them at the end of the day, because even in certain institutions, you have physicians within the department that are sometimes a little bit more conservative, or they want to wait a little bit more to put the patient on ECMO. Yeah. So that's my role, is kind of just like to let you know that specialty care is here for you. We want to let you know that you have the resource available, and the information is as up to date as possible. And you guys can use it however you want to.
Yeah, and if you do choose to use it, you are there to support them in doing so.
Absolutely.
Yeah.
100%. I think to get back to your question about using respiratory therapists and nurses with ECMO.
Yeah.
So one of the things that we find is that perfusionists are limited.
Yes.
Especially with like the limited schools, how small the programs are, that kind of stuff.
Well, and there's staffing shortages for perfusion.
Exactly.
That's probably the best medical field to get into right now because everybody needs them. Yeah.
And I toyed with the idea of going back before, like getting into a leadership role.
Yeah.
But what you're finding is that these perfusionists, you expect them to be in the OR for your cardiac cases.
Yeah.
And they're there from 6 a.m. Sometimes earlier, depending on the institution that they work for. And then after their day is complete, you want them to take care of an ECMO patient.
Yeah. When do they go home and sleep?
Exactly.
Yeah.
And there's no way that you can have somebody at the bedside 100% of the time to support this patient from a ECMO clinician standpoint by just having the perfusion team, especially with them being in a national shortage. So you're finding that a lot of these programs, they're gravitating towards this like RT or respiratory therapy and a registered nurse model. And that seems to be working really well because that allows, like 24-hour coverage. You have nurses that are coming in. You can handpick the best of the best from your team who you think would make a good ECMO specialist.
Sure.
Especially like you get to see what positive clinical impact they've had in their entire career, and you can tell based on that impact, will they be a good ECMO specialist or not? Because like some centers, the medical team, they're a lot more involved, but for a lot of centers, it's protocol driven. So they're putting the trust in the bedside ECMO specialist that you kind of know what you're doing and doing what you're expected to do competently and appropriately.
Sure.
So yeah, I think this new or newer RTRN model is working really well. And it's kind of like getting away from that burnout that a lot of perfusionists are experiencing.
Yeah, they're sort of stretched thin. So with the RT or RN sort of support model, do you, as you're training them, I'd imagine that you are reaching out and saying, hey, do you have new respiratory therapists or RNs that need to be trained for ECMO specialists? And then you sort of walk them through how to, correct me if I'm wrong, use the machine, what the vitals are supposed to look like, all of that.
That's a part of my responsibility as an educator. So I work with the VP of perfusion and the VP of ECMO, and kind of devise a strategy for how we're going to go about, like implementing an ECMO program at these facilities.
Sure.
But they reach out to us, or business development people reach out to them, and kind of like present the pitch for what benefit an ECMO program will bring to their institution. And from there, we kind of devised from a clinical standpoint how to best go about, like building the program, establishing the program, and getting them on their feet.
Okay. It sounds like you are sort of the first person they talk to once they sign on to start an ECMO program with SpecialtyCare.
From a clinical point.
Yeah, you're the person that says, here's what you need to do to get it up and running.
And I think that's what, because obviously getting a program up and running isn't solely just from a clinical perspective. You have to think about the management perspective.
Oh yeah, it's staffing, it's budget, it's all of that.
Exactly.
Yeah.
The staffing, the budget. For me, it's beneficial having the ECMO coordinator experience, because that role, you get to see the behind the scenes of how things work, and you kind of, like, it definitely was eye-opening, I will say, and stressful, because you're kind of like the point person, the person that when a kid comes in, or because I worked in pediatrics, when a patient comes in cardiac arrest and they're actively doing CPR and they're calling you at home to come in and be able to get the pump primed or get the pump on, it kind of is just like stressful, and the burnout definitely is real. But I think that coordinator experience definitely was beneficial in being able to like take a step back now and be able to offer that advice for hospitals that are, like trying to build a program.
I would be more comfortable if I was a specialty care account or hospital or however that is phrased, knowing that the person who is showing me how to do it, how to run an ECMO program, has done it themselves and has a lot of experience in doing that specifically. So it sounds like that's sort of what you're drawing on when, you're talking to these people. Like, you were the go-to person. They would call you at home and you'd drive in and, you'd work with these kids. Yeah.
Yeah. Definitely is a team effort.
Oh yeah.
And of course we have the backup, we have our perfusionists on backup, but of course you don't want them to, like have to come in to help put a patient on ECMO at 3 a.m. if they have to pump a case at 7. So you kind of like reserve them for when you actually do need them and give them that opportunity to rest and recoup, and because the last thing you want to do is burn them up.
Well, Kurt, I think I'm going to leave it there for this episode of Checking the Vitals, but I really, really appreciate you taking the time today to talk to us about sort of your career path, but also ECMO in general, because you're the first person we've talked to about it.
Thank you, Todd.
Absolutely.
Anytime.